Yeah, good evening, and welcome all colleagues to our session now. Yeah, for our first speaker, I would like to invite Dr. Rajinikanth Rajagopal will present the drug-coated balloon in the de-novo coronary disease, where from and where to. Yeah, please.
Thank you very much. My name is Raj. I'm from Brunei. The topic is drug-coated balloons in de-novo coronary disease. Where from and where to? Figure this out. Is it the mouse? Yeah? Okay, so no disclosure. So we'll start by looking at a piece of art. Just to slow things down a little bit. So this painting is what inspired the topic. It's by a French artist called Paul Gauguin. It's called Where Do We Come From? What Are We? Where are we going? So looking at the painting from right to left, it talks about life, being born, growing up, getting old, and dying. So it's his masterpiece. It's also a philosophical work. So I don't think anything is dying. I don't think skins are dying. I don't think DCBs are going to die anytime soon. But I think there's a change in philosophy when you go from DES PCI to DCB PCI. And that's why I thought this could be interesting to look at. So we're going to look at it the same way, looking at DCB, PCI. Where do we come from? Look at the evolution of PCI with respect to DCB. What are we? Look at an overview of DCBs. How do we do it? Existing indications, and move on to expanding indications and evidence that's coming in the near future. So where do we come from? So if you look at PCI, this is absolute basics of DCPCI. I thought it will be useful for people who are really new to the concept. So we have a lesion. We do balloon dilatation. Angioplasty, we get a good result sometimes. Sometimes we get dissections or residual stenosis. If we have dissection or stenosis, we need to put in a stent. Sadly, even when you have a good result, we tend to put in a stent, which is probably unnecessary, mainly because we can get instant restenosis and we can get stent thrombosis. In addition, we cage the vessel and we get loss of vasomotor function. We can't have late lumen gain. So we need to go back, take a step back and look at why we are doing this. We worry about vascular injury that can lead to neointimal proliferation. And for that, we need a drug. And that can be hypersensitivity to the polymer or to the metal, inflammation. For that, we just need to avoid metal and avoid polymer. And thus, we have drug-coated balloons. So we rethink PCI. So if we have a problem with dissection or flow limitation or stenosis, we put in a stent. But if you have a good result, we don't need to put in a stent. A DCB to deliver the drug is adequate. And we are, leave nothing behind. So if you get good, adequate angiographic result, and we can end up with a DCB with less late lumen loss and even positive remodeling at times. So that's that's a philosophical shift to DCB PCI. So what is a drug-coated balloon? It's a balloon catheter with a drug coating, either paclitaxel, sirolimus mostly, and an excipient or a carrier to regulate the drug delivery. So remember, a DCB only delivers the drug. It is not a mechanical device as such. Lesion preparation is completely separate. So there are many DCBs in the market, and you can see the difference. There are paclitaxel and sirolimus DCBs, and the doses are different, the additives are different. So each DCB is different and need to be understood on its own. There is no class effect for DCBs. So the difference between the two drugs, sirolimus is a safer drug in a way. It's not cytotoxic, and it's got a broader therapeutic window. Paclitaxel, though, is lipophilic, which is a good thing because it binds well to the vessel wall, and there is more evidence of late lumen gain with paclitaxel. So in a way, sirolimus is probably a better drug, but paclitaxel makes better DCBs. There are no major guidelines at the moment for DCB in de novo disease. It's mostly based on recommendations and consensus documents. So we look at the technical aspects, how to do a DCB PCI. So we'll just use a very, very simple case to understand, this at least the way I do it and a lot of us do it. So this is a gentleman with bystander focal stenosis in a circumflex. You can see it there. So this is my approach to DCBs in general. I usually start with a very small scoring balloon, 2 millimeter. But if that can't go through, I start with a very small semi-compliant balloon. Then a scoring balloon. After this, we do imaging, either OCT or IVUS. And then we do further vessel preparation with NC balloons or scoring or cutting balloons, IVL if it's calcified, rotablation if required. the most important step is to get a 1-to-1 NC balloon. And if that expands well, then you can do an angiographic assessment. Some people like to do FFR. I don't normally do that. And if that looks good, you deploy a DCB. If it does not look good, which means if there is more than 30% residual stenosis or a flow-limiting dissection, we need to go for a bailout scan. So we'll see how that works in reality. So before that, scoring balloons are really important in DCB PCI, more so than scan PCI, because you get better block modification, because the pressure that you exert is focused on the scoring elements. You get increased compliance. The balloon doesn't slip with the scoring balloon, so less damage, less injury zone. And there is some evidence that the drug might be better absorbed after a scoring balloon. So my practice is to use an upfront scoring balloon, which may improve the procedure result. So here, we started with a scoring balloon, just a 2 millimeter scoring balloon. Then we do imaging. So the role of imaging in DCP-PCI is slightly different. It's probably less important in some ways compared to scan PCI. Pre-PCI is very, very helpful because you can do vessel sizing. You can look at the morphology and calcium assessment. In post-PCI, imaging is less important than scans. You can look at the lumen gain, which is quite helpful. But mostly decisions are made based on angiogram. So we should not worry about dissection seen on OCT and decide to scan a lesion. So in this case, we did some imaging after the scoring balloon, saw some controlled dissection, looked at the vessel diameters, then did a 1-to-1 balloon dilatation. At this point, we assess the vessel. We look for two things. Look for dissections. If it is type A or type B, it's okay. Anything more than that is not okay. Similarly, recoil. If it's less than 30%, you're good to go with the DCB. If it's more than 30%, you need to improve on it. You can try further expansion with a scoring or cutting balloon or an NC balloon. And if it's better, you go for a DCB. If not, you may have to put in a stent here. So in this case, we did angiogram, we did a repeat OCT, with a bit more dissection, better lumen gain, and then we deployed the DCB. So DCBs need to be deployed for about 30 to 60 seconds. And once you get it into the catheter, it's got to be deployed within about 90 seconds. Otherwise, the drug might wash away. Guide extension could be helpful. Distal lesions, tortuous lesions. You don't want to have, if you don't deliver the balloon in time, you're going to waste it. So here, guide extensions might be useful. And then you need to do a final angiogram to assess that everything is okay. Wait for a couple of minutes, and then do a final check angiogram. Bailout stenting, like I said, if there is significant residual stenosis or dissection. If you put in a DES on top of a DCB, there is no huge concern about double dose. And you don't have to scan the whole segment, just where there is significant dissection or stenosis. Avoid edge dissections. It's okay to leave behind a dissection after a DCB, but not at a scan edge. That's a completely different concept. So we should not leave scan edge dissections. That's important. See the difference. Right here, this patient was part of the Transform 2 study, was randomized to DCB. So we put in a DCB and we got a good final result. So that's how we work in. So that's a general, often quoted illustration. You do optimal lesion preparation. If you get acceptable result, DCB. If it's suboptimal, you put in a drug-eluting stent. So look at a slightly different. So these are the indications. So we are looking at what we saw earlier was a small vessel, but a discrete lesion. But often you get this in a diffuse disease where you might go for a hybrid PCI with a combination of stent and DCB. So look at one of those examples, a small vessel diffuse disease where you normally get higher complication rates with stents, and DCB could be a better option. We've seen the evidence from all these studies which show that DCB is non-inferior or superior to stents in small vessel disease. So this lady was a 44-year-old lady with an STEMI, severe 3-vessel disease. You can see that LAD is horribly diseased all the way from proximal mid to the distal, as is the circumflex. She was turned on for CABG. And so we decided to pursue a hybrid strategy here. So we did serial pre-dilatation, semi-compliant and scoring balloons, finally a 1-to-1 NC balloon. We did IVUS sizing, and we did a hybrid PCI with 2 drug-coated balloons in the distal and mid LAD and a long stent in the proximal vessel. And we got some dissection in the distal stent edge. We put in a second stent just to cover the dissection, and later finished PCI to the circumflex with a stent. So this was a final result. So here you can see that we put in a stent only in the proximal to mid LAD, and we put in 2 DCBs in the distal LAD. It was satisfactory because we had good lumen expansion, no significant dissection. A month later, she came in for a stage PCI, looked at the LAD, it looked better. And what we did here was we avoided metal, and we not just saved a target for lemur, we created a target for lemur. She's only 44 years old. In the future, if she has some ISR in the proximal stent, needs a lima, it becomes an option. Different patient, a 71-year-older lady here, with, again, diffuse disease, but heavily calcified. So the whole LAD is severely calcified. It's some ostial stenosis. Here we did rotablation to the LAD, and then we did assessment with angiogram, and IVUS showed some improvement, good result from the rotablation. Further vessel preparation with NC balloons in a sized up to 3.5, assessed again on IVUS and angiogram. So here, if you put in stents, we're going to have a full metal jacket all the way. And in a patient like this, that's a very high risk of ISR or stent thrombosis. So what we did was we put in 2 DCBs in the distal LAD and the mid LAD, and just put a stent from the left main into the LAD. And we got a very reasonable result. Here, sorry. It's my time over already. Thanks. Right. So we brought her back about a year later, and we could. Yeah, doesn't it? Check. All the mics, okay. I'll just talk, it's okay. Oh yeah, it's working again. So there was, we brought it back a year later. We saw some ISR in the left main LED, which we fixed. And in the DCB treated segment, we saw focal restenosis, and which we treated with a short stent, 30 mm stent. So eventually, she did end up with about, a stent in the left main LED, but all the distal LED, we were able to just manage with a DCB, which is, a good result for her in the long run. And so that was a follow-up result. All right, so the concept of DCB in small vessels, it's non-inferior, hybrid strategy in long lesions, reduced stent length. You could get late lumen gain. CT or PCI is particularly suited for this, and we could follow up with angiogram or CT in selected cases. Bifurcations is a really strong indication for DCB PCI. Broadly, 3 situations where we can use it. In the side branch alone, where you can use it along with the stent in the main vessel, or after you put a stent in the main vessel, if you have some compromise instead of an NC balloon. You could do main vessel PCI with DCB, or which reduces your risk of compromising the side branch because of avoiding metal, or you could do in both side branch and main vessel. This is a young chap, a 49-year-old with posterior MI. He had ostial occlusion, and after restoring flow, we just did DCB, and we got a good final result. He came back for a stage PCI for the LAD, and at that time the OM looked bigger, which you would expect following an MI, and had a good result. And this is a chap with LAD D1 disease, where we did, after good vessel preparation with a cutting balloon in the diagonal, did a DCB in the diagonal, stent in the LAD, good final result. And when we checked him a year later, diagonal looked even better. And there is a new study called the DCB BIF trial, where this is after provisional stent in the main vessel. If there is compromise of the side branch, instead of an NC balloon, a DCB might actually improve the long-term outcomes. And main vessel, this is a very simple case where a lady, 54-year-old lady, had focal stenosis in the LAD. Diagonal had no significant stenosis. We just did a DCB in the LAD and I had a good result. Now this is more interesting. Main vessels and side branch, bifurcation stenosis. I think there is good reason to think about DCB here. So here we prepared sequentially with scoring balloons in the main circumflex and in the OM. And after looking at the result, we deployed sequentially, first a DCB in the OM and then a DCB in the circumflex, then pulled the balloons back a little bit and did kissing balloon at low pressures with the DCB and got a very good final result. Some people like to deploy both the DCBs at the same time. So that's also an option. I think it's individual preference. And this can be applied in trifurcations as well. This is an ostial circumflex trifurcation where stenting would have made things really complicated. Had to come back to the left main and so on. Using a similar principle like the last case, we did imaging-guided preparation and 2 DCBs, and we got a good final result, and 2 years later, the result was still good, avoiding metal completely. So these are the various indications where DCB could help in bifurcations. High bleeding risk. This was a lady with cancer who was noted LAD treating, but also might need surgery. So we just treated the whole LAD with just DCBs, and we could give her a permission to stop DAPT even after 2 weeks if required. And so she has done quite well subsequently. Aspirin allergy is another indication, straightforward case. So I was going to skip all this. So that's CTCA is a good way to follow up after DCB PCI. So ACS, I think in the interest of time, I'm going to just say the summary. DCB in ACS could be useful to simplify procedures. Apart from usual benefits, it can be good because when there is large thrombus burden, you can do thrombectomy, bring back a couple of days later and just defer PCI with this DCB. And in erosions where you don't want to put in a stent, a DCB may be a good option. We won't look at the case examples. I'm going to move just to the last part of it, expanding indications. I think there are two big trials underway for larger vessels. The solution trial, looking at solutions, sirolimus DCB. Here, the patients are randomized before the vessel preparation, and you have the Transform 2 trial where their vessel is prepared, and then they get randomized to DCB or stent. And it's important to appreciate the difference between these kind of studies because when you are randomizing before vessel preparation, you're comparing strategies. If you're randomizing after vessel preparation, you're really comparing the devices. So it's important to analyze evidence carefully. I think future trials should look at different settings. I think techniques will have to be standardized when comparing devices. And we have to look at DCBs in various clinical settings. So DCB restenosis could be a new problem. You have to figure out how to handle it. So to summarize, DCB in de-novo PCI, we need to rethink. There is no stent at the end of it, so every step in angioplasty is really important. Vessel preparation is key. We need to achieve lumen expansion with no flow limiting dissections. Hybrid PCI could be helpful. It's not about avoiding stents, it's about limiting stents. And indications are expanding with experience and with growing evidence. Thank you very much.
Thank you, Raj, for your excellent talk. So we may entertain one question from the panelists or any burning questions. So in your practice, how often do you use imaging to size the pre-dilatation balloon and also the DCB?
So almost every case. So generally, 90% of my PCI is done with imaging, and it's mostly OCT. So I don't make a difference whether it's stent. I start every case as if it's going to be a DCB case. So I do about 60–70% of my cases with DCB. So every case done with imaging, pre-PCI. And if it's going to be a DCB, I do not always image after pre-dilatation. It just confuses you. I will go with angiogram.
How about if you size according to imaging, do you size to the lumen or size to the vessel size?
Lumen, absolutely. So with OCT, I go lumen to lumen. So it's a bit conservative. So my colleague who uses IVUS more often is more aggressive. And I don't think you need to be that aggressive with DCBs. That's the beauty of it. With the stent, bigger the better. With DCB, you don't need to be that aggressive, and it seems to work well.
And excuse me for the cancellation. Do you do the DCB?
Absolutely, yeah. So, I didn't bring the cases here. So we showed one case where we had rotablation followed by DCB, and with IVL it works really well. So once you have done IVL, if you've got a good lumen expansion, DCB is all right. But it's important to remember that if the calcium is superficial, it will impair the absorption of the drug. So we had to look at that, and there are some, and if, so it still works. If you get a good lumen expansion, you don't need to put in, and if there's no limiting dissection, we can use DCBs if there is a good indication. Calcium nodules, I don't know. I have tried a few cases with calcium nodules, done rotablation, done IVL, and then put in a DCB. They have come back after a year. But for every case, I've had at least 2 or 3 cases where I put in a stent, and they have come back after a year as well. So I don't know the answer yet.
Thank you. For the interest of time, we'll move to the next presentation.
I would like to ask you one question.
Yes.
You had the DCB in the left meninge or not? Left meninge. Have you ever had experience in the, yes, you?
So far, I've not had a reason to put a DCB in the, I've done ostial LAD, but I've not done left main LAD. But if the situation, like my lady with cancer, if someone like that, needed PCI and needed surgery within 1 or 2 weeks, I would not hesitate to do PCI with DCB. But, it's not about, if there's a good indication, I would do it. Thanks.
Thank you, Dr. Raj. Thank you. The next speaker is Dr. Huan. Dr. Huan will talk us some tips and tricks on the use of BOTA.
Good evening, Chairperson and panelists. Now we talk about rotation, rotablator. We know that the cardiovascular disease is the biggest killer in the world. Is account for more than 10 million death in the world over the COVID, stroke, COPD, and lung cancer. The PCI worldwide increased rapidly. We know that more than 10 million of people under BCI a year. In the left side, we do the statistics from the Sweden. From only 5 years, the number of BCI increased 2.5%. And the left side and the right side, we see that statistics from the Japan and US show that only from 2030 to 2017, 2.5 time increase the number of PCI. In Vietnam, statistic from Vietnam 2023, 140 BCI center in Vietnam, and more than 50,000 patients under BCI. When we do the angiogram, the review and meta-analysis, over 1,000 patients show that half of the patients have the moderate or severe calcified. And the frequent from the 13 study DS, rare, serious, taxus, etc., show that the pool of calcified lesion more than approximately 30% of the patient. And syntax trial, intersect trial, more than 50% of the patient have the moderate or severe calcified. And we look at the study acuity and horizon. 1/3 of patients have the calcified lesion, and 6%, nearly 6% of those patients have the very heavy calcified lesion. And the calcified lesion impact to the result of the BCI procedure. Final TIMI flow 1 and 0 and 1 increase compared with the non or mild calcified lesion. And final no flow more than in the arm of the moderate and severe calcified lesion, and dissection across more than in the moderate and severe calcified lesion. And for 1 year ischemic outcome, the MACE definite as the elevation, death, cardiac death, and death more than in the patient with the calcified, more heavy calcified lesion compared with the non or mild calcified lesion. In the ADAPT DS population, totally nearly 8,500 patients, 30% of patients had the moderate or calcified lesion. And we see that the MACE, MI, TVR, major bleeding, late bleeding in the patient with the calcified lesion more than the non-calcified lesion. And when we use the first or second generation of DES, the result are the same. It means that the calcified lesion impact to the result of PCI. The pool analysis from 7 contemporary stent trials show that if the patient has the calcified lesion, the result, the death, the cardiovascular death is double compared with the non-calcified lesion, and death, MI, or death, MI, and cardiovascular event more than in the calcified lesion. And when we do the angiogram, we show that we can see that if the patient has isolated spot on radial opacity on the left side is the mild calcified lesion, moderate when we see the radial opacity during the cardiac cycle, and when we see the cardiac radial opacity observed without cardiac motion in the both side, we see that is a very calcified lesion. On the image, intravascular image for IVUS and OCT, we define that concentric, eccentric, and nodular calcified lesion. and differ for the cancer from the arc of the cancer severity. If the arc 360 degree is the severe arc, and we can define from the arc and the length of the calcium severity. We are different more than 5 mm calcified lesion and less than 5 mm calcified lesion. For the thickness, or if the patient in the coronary artery, the calcified lesion less than 0.5 mm is not so severe, and if the calcified lesion more than 0.5 mm is severe lesion. And the death, the superficial death, or we see that the death of the lesion. One is the trial from Dr. Trung show that when we do the angiogram and we do the IVUS, we will put the score. We will put a score for the calcified lesion. If the calcified lesion more than 270 degree and more than 5 mm, then this is one point. If the arc 360 degree of calcium 1 point, calcified nodum 1 point, and vessel less than 3.5 mm, this is 1 point. We show that if the calcified score from 0 to 2 score 2 point, the stent deployment more than 70%. If the point is 3 or 4, the stent deployment less than 70%. And therefore, if we put the score for the calcified lesion, if the calcified lesion more than 3 point, we put modify the calcified lesion. For IVUS, the study from Dr. Akiro Fujino show that we put the point for the calcified lesion based on the maximum calcified eagle, more than 180 degree, 2 point, maximum calcified thickness, more than 0.5 mm, 1 point, calcified length, more than 5 mm, 1 point, and totally 0 to 4 point. And we show that if the patient has the 1 point in the left side, the stent expansion is 97%, 2 point, 1 point, 99%. If the patient had the more than 3 point, the stent expansion is less than 70%, and therefore, if the patient have the 3 point on IVUS, we should modify the calcium lesion. We have the two techniques, balloon-based technology and atherectomy device. We can use the balloon or intravascular lithotripsy or rotational atherectomy. And for the rotaplator, the study rotasus with the 240 patients divide for 2 arms, 1 arm rotaplator, and after rotaplator put the DS and other arm conventional PCI. And we show that if the patient well prepared the lesion, the lumen rate better than when we don't prepare the lesion. And the maze DLR MI that less than in the arm of the rotaplator. And when the heavy calcified, there is 22% crossover from the balloon to the rotaplator. And 2 years adverse outcome that when the patient use rotaplator is better of that adverse outcome better in the arm of rotaplator, and prepare calcify recent, they compare rotaplator and scoring balloon, and we see that 200 patients include to the study 1 and 1, and strategy success when we do the rotaplator, the successful when we do the PCI better than if we do the scoring balloon alone. And some patient, the author cannot cross the any balloon or modify balloon or any not adequate dilatation, and they should use the rotaplator. The 5 years follow-up of the prepared calci of the calcified in the arm of the rotational atherectomy, the TVF is less than TVF is more than cutting balloon, and TLR is less than less in compared with the cutting and scoring balloon. SCAI consensus algorithm 2023 show that if we do the angiographic, if the image show that the patient had the heavy calcified lesion, we should prepare the lesion by scoring balloon or NC balloon 1 to 1, 1 to 1. If we cannot cross the cannot cross or the lesion not good prepared, we use the rotaplator. If you have the intravascular imaging, we give the point for the patient for the lesion. If the patient have the 3 more point on IVUS or on OCT, we use the rotaplator for this patient, and the result will be better. This is one patient with when we do the angiogram, we show that the patient had the very heavy calcified. We see the image opacity in the both side of the coronary artery from the left main to the mid of LED and the circumflex. And when we cross the wire, we cross the wire. We use the small balloon, but not cross the small balloon 1.5 mm. We use the rotaplator, and the final result. Is good for take home message. The patient with the moderate and severe lesion calcification of coronary artery is account for a high proportion of coronary lesion and associated with the greater rate of death, MI, TLR, and stent thrombosis compared with the non-calcified lesion. During PCI of calcified lesion, IVUS OCT are useful to determine the extent of calcification and optimize the stent result for MSR, geographic coverage, and age issue. We use only the scoring and cutting balloon in the situation that if the lesion have the moderate calcified lesion. If the patient has the severe calcified lesion, with my experience that better we use rotaplator upstream for the patient, better we will have the better result. Atherectomy provide effective lesion decalcification and improve vessel compliance, facilitating stent delivery and expansion, decrease rate of death, MI, TLR, and stent thrombosis. And we don't forget that for rotaplator, the first if the very severe calcified lesion, the burr 1.25 mm. We don't use the burr 1.25 mm because it could be stuck in the lesion. Normally, I use the 1.5 mm for the first use. And in some patient, and we use the cutting balloon or NC balloon dilate before we deploy. I deploy the stent. And if the result we not achieve the good result, I upgrade the burr 1.75 mm. Thank you for your attention.
Thank you, Professor Huan. Any comments about social?
Yes, so I already talked about the calcium. So as you mentioned, IVAS and OCT measurement is very important, and also we can speculate the lesion will expand, or so that we can deploy the stent, or so Raj already talked about the DCB is better in such kind of situation or something. So its imaging is very important, and so for the so for example, distal part of the small vessel at that time. Of course, proximal part we can assess that stent or enough dilation. For distal part at that time we sometimes use the DCB. How do you think the distal part of the calcified lesion?
Yeah, it depends on the myocardium. Because if the area of myocardium more than 10% of whole the heart, we should do the PCI. And first we use the small pore. Yeah, if the small it is a small vessel, but we define the small vessel when the vessel is 2.5 mm. This is small vessel, and if the 2.5 mm, normally we use the 1.25 burr for the first time we use.
And DCB is also the one option, such kind.
Oh yeah, DCB is the one option.
Okay.
Okay, and I would like to invite Professor Lam Ho. We will represent the use of hemodynamic index in the chip management. Please, Professor Lam Ho.
Okay. Good afternoon, everyone. Thank you. So this is my topic. I hope through this presentation, everyone have some inspiration and about the future trend of PCI and also the use of hemodynamic. So if you go to meetings, no matter where you go, you will see lots of studies were published, and most of the time PCI was defeated by metal treatment or defeated by CBG. So in the future, how should we go? Next slide, I hope. Yeah. So how can we defend ourselves in the future? I think about fee strategy. We classify the case into low risk case, high risk case, and extremely high risk case. For low risk and moderate case, we just consolidate. Because PCI is minimal invasive, you won't do a type A lesion in AD with CBG and the open heart. So you can just consolidate the advantage of PCI. For high risk case, left meningeal multiple vessel disease, we just keep fighting. And we should also explore and dominate in those extremely high-risk cases, which cannot be treated by medical treatment, and surgeon will never touch. For those cases, never have evidence. Most of those cases were done by your logical deduction or logical thinking. And hemodynamics is very important in those cases. I will try to use one case to illustrate this concept. The patient was 40 years old, just very, very young. This time was admitted for delayed STEMI, APO, short, and multi-organ failure. You can see from the renal function, renal sunk down, potassium very high, sodium very low. And you can see the liver function, ALT, ALP sky high. Congested liver, chest X-ray, the bilateral lung were congested. CHOP I and CK were a bit low because delay percent. Glucose very high, 31. So multi-organ. And we had done the echo, and you can see the patient EF was just 30, and the patient had moderate to severe MR. So in this sort of case, of course, we can find surgeon, but surgeon will decline, and patient will die if you just do medical treatment. So this sort of case can only be settled by PCI, in fact. So can you pay the angiogram? This was the angiogram, third was CTO, and there are critical lesion over the AD. And if you do PCI, where is the landing? Where will you land? Yeah, it's difficult to decide, right? Will you land over here, 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 or where? And this was the angiogram on the outside, yeah, also outside, and then like that. We actually with the IFAS, we found also AD and also SWET are also very tight with heavy part burden. So, of course, impossible. Surgeon won't touch, never touch those cases, right? Anyone see surgeon touch this case? Never, yeah. But yeah, we have to save it by PCI, but how can we save it? Yeah, the first thing you must have MCS support, either ECMO or impeller. Without MCS support for those cases, just dreaming, you touch and the patient will arrest on the table. Yeah. And then with support, and then we finish the PCI on the outside first. Okay. And then if we want to have good outcome on those cases, imaging is very important. Like this case, it's difficult to judge where to land. However, by IFAS, you will know where to land. Like this case, we decide to land here. It's based on the IFAS finding. And you need to choose a stand with least homogeneity. That's very important. And then we finish the PCI on the AD. Yeah, and also the... Okay. 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 The story, of course, will not end like that. The patient was stable after the procedure with impeller, and we wean off the impeller at day 3 because it's a very small body build lady, and with impeller and with some hemolysis, you have to take it off. And the patient is still stable, just on low dose dopamine, which was given for small inotropic effect, some renal protection, and some for slightly for the BP. And the patient was stable, borderline stable for 2 days. But one night, on call doctor, because nowadays many studies said dopamine is not good, have to change to noradrenaline. So then it changed to noradrenaline, low dose. But the patients deteriorate. Why? You look at the difference between the noradrenaline and dopamine. I did not. It's just no evidence, so I cannot write on paper what happened. And you can see from the pharmacology. If you use noradrenaline, in fact, it will increase the systemic vascular resistance. It's much more than the dopamine. So after change to the noradrenaline, the patient rapidly deteriorate within 1 night. This was the chest X-ray, and I try to explain this. Why will this happen? It's because in our body we have dual circulation. One is pulmonary, one is systemic. The patient had very dry in systemic circulation, but very wet in pulmonary circulation. So is it possible? So it's really possible. You look at here, just after 1 night noradrenaline, the patient become very dry. On the peripheral, you can see increase in urea and creatinine increase. It's because the peripheral vasa constrict, poor perfusion. And on the same time, you see the chest X-ray, bilateral lung even more congested than before. Why? It's because it increased the systemic vasa resistance. The patient had acute MR, quite moderate to severe MR. If we put noradrenaline, increase systemic vasa resistance, you can imagine the acute MR will increase, pump more blood to the lung. But at the same time, because more blood go to the lung, then less blood go into the systemic circulation. That's why the systemic circulation become dry, renal sundown, and at the same time, bilateral lung were congested, even more congested than before. And you see the urine output decreased to 10 ml per hour, and systolic BP was just 80. This was the highest LVN dissect pressure I never see, is 50. Yeah. And how to treat this situation is, we say, is internal wet but outside dry. You give fluid, the patient will have congested lung, intubation. You give inotrope, it will venous sung down and more pulmonary edema because increased afterload. Yeah. Feels my already very dry peripheral because the doctor also give Lasix. Yeah, feels my. So that's why you can see the urea increase and venous sung down. Peripheral was dry. So how to treat your clinical judgment and thinking? Yeah, the way of thinking very important. So how to treat this situation? Systemic dry but pulmonary is very wet. So the principle is increased contractility, and we put the patient on BiPAP, increase PET, that means increase the pressure in the lung. And also, we try to reduce the systemic vaso resistance. There is an interesting saying, is use cardiogenic shock to treat cardiogenic shock. Drop the PP, further let it drop, and then so that she can survive. Is it possible? Use toxin to treat intoxication. So drop the systemic vaso resistance so that more blood will go to the systemic and less go to the lung. So how to do it? We do a safe and saving shot. We put the patient on impeller again. This time we use 5-inch ankle pick so that we can enter more precisely, had less hemolysis. You can see the lung at that time was very, very bad, almost white out. We put the patient on impeller, so 2 impeller in this case. And then this time we used inodilator, not dopamine or noradrenaline, use dobutamine because in low dose, in fact, it will decrease systemic vaso resistance. Although it's inotrope, inodilator is inotrope plus vasodilator. And then on top of that, despite the patient's BP around 80s, we give TNG, further drop the systemic pressure so that the systemic vaso resistance will decrease. So we give dopamine plus TNG infusion. So is it possible? But I would remind you, don't do it without impeller support. You can imagine those short case, unstable case, you give these 2 things and then the patient further drop may just deteriorate. But if with MCS support, you may be able to do this. So this was the hemodynamic. That is the most important thing. Most of the time, the white heart cath findings are not useful, are not reliable, but they can help you to understand all the things. Like this case, this is the BP after injection of impeller and with dobutamine. It's 80 something, CVP was 13, but the wedge is very, very high, 32. That's why you can see the lung was white out, and the cardiac output was 4, and this is very important finding, CPU cardiac power output. If it's less than 0.6, then that means very likely the patient is in short in hemodynamic compromise. So we calculate all these things with impeller, and then we see that this is not acceptable, so we further give TNG. After the TNG, the patient's systemic BP dropped from 87, dropped to 77. CVP drop, you can see the wedge also drop because systemic resistance, the afterload decreased. And despite the BP was dropped, but the cardiac output were increased to 6.8 liter, and the CPO increased to 0.68. So that is to drop the blood pressure, drop the afterload, and then increase the cardiac output. So BP just a BP, but it's not cardiac output. That is the major concept on hemodynamic. And further improve the patient's cardiac output, everything, but BP do not change. Yeah. And this was calculated by Adam. We calculated by app. You can go on internet and then try to just take the photo and then calculate the systemic vaso resistance. It really dropped after the TNG. And cardiac output increased. So afterward, you can see we really give dobutamine and TNG infusion at the same time, low dose dobutamine plus TNG. So the urine output increased back to normal. and remember, you keep the impeller in P3 to P4 only, otherwise you have hemolysis. With the patient with severe MR, moderate MR, very likely will have hemolysis. So you have to keep P3, P4. And day 2 after impeller, we give levosimendan, which is a long-acting immunodilator. It also causes decrease in systemic vaso resistance, but increase in inotropic effect. So in the tips and tricks is no loading, just give it as infusion. And some days later, the patient fully recover and discharge unaided. We know everything, lung, everything okay. So that is a case to illustrate how to save extremely high-risk case with PCI. You need device, you need thinking, judgment, and you need some knowledge on hemodynamic and also drugs. Those are very important things. That's the end of my presentation. Thank you.
Thank you, Dr. Lam Ho, for your excellent case. So I have a question. I have some comment, actually. So you see from the blood result, initially there's impaired renal and also liver function. Yeah. So it means that, as you said, is the patient has gone into the stage of hemometabolic shock. And MCS is definitely needed. So if you have impeller, go for impeller. If you have IBP, you need to go for IBP. And this patient is also having the QMR, so she may actually benefit from IBP too if you don't have impeller in your center. And if you need to do PCI, because PCI is going to get the patient worse before better. So even though you see the guiding, you wire the balloon, everything is the insult to the heart. So you need some support before you can do the PCI. So always IBP first before you touch the coronary. So the other thing is, because you know impeller very expensive, once you remove it, you reinsert it, you double the cost. And of course, alternatively, you can also try IBP as you have already hemolysis from the first impeller. And if you have IBP, you then, of course, noradrenaline is good. It's good because it's actually from a sub-analysis of the SOP2 trial that in patient with shock, in a subgroup analysis, is cardiogenic shock. The dobutamine may have more AF and also VT. And noradrenaline is not always good. You need a central line sometime. Although you have peripheral formula, you can use a diluted form to do it in the peripheral line, but you need to central line most of the time. And the other thing is increased afterload. And in the acute MR patient, afterload increase would worsen the case. So you have to support the blood pressure and then give some vasodilator to decrease the afterload and improve the cardiac output. So this is the main point Dr. Lam Ho is trying to convey to us. Excellent case.
About the noradrenaline, if you have some acute MR case, if you may try and you will see the effect. It's quite dramatic. After noradrenaline, most of the case will deteriorate.
Yeah, sometimes ischemic MR won't improve after the intervention, especially for delayed presentation. So sometimes if it doesn't improve, we may be end up difficult because if you have triple vessel disease, you fix the coronary, but you can't fix the MR, and you may end up like the surgeon won't do. If the first line is still the surgeon, but if the surgeon turns down, we have no way we can do PCI, and then it doesn't improve it, we do the clip or some other structural intervention. So this is the comment.
So, I have a comment. So I totally agree that in this kind of situations, I think mostly 100% of surgeons will refuse the case from the very beginning. Or they just tell us, you stabilize first, and then I will do surgery. But how to stabilize? Really no. And then I have few cases of like this one. We try to save the patients by IBP because impeller is not available in Vietnam. And they have to do PCI, but I see most of the case die a few days later because of multi-organ failure a few days after all. So, but we don't have impeller in Vietnam, but ECMO, we have some, because after the COVID, then ECMO becomes more popular in Vietnam. So my question is that in case of impeller is not available, then can we use ECMOs from the very beginning? And then one of the disadvantage of ECMO is that the afterload, there are a few days up, and then there's some data that then you combine ECMO and IBP later on.
Yeah.
Okay, so what do you think?
Regarding the question for ECMO, I will recommend you not to use ECMO in those cases. Most of the time, you just worsen the situation. The ECMO increase the afterload much more than noradrenaline. The aortic valve won't open, it just force all the blood to the lung, and then you will have a very completely wide out lung. And you can't win off the ECMO. Yeah.
So if you cannot use Impera at that time, the another option is only IABP. IABP is somehow so supportive, but so it depends. If the blood pressure is too much low during the PCI something at that time, so of course we mandatory use ECMO. But so just for PCI, so IABP is one option. If we can use Impera, of course it is the most effective in this situation. But depends on the financial cost or anything.
For MOUs, really need to be careful if there's MR. Yeah.
So let's have the next speaker, Dr. Nguyen Trung. He's going to share with us the must-know technique to protect the side branch in bifurcation PCI.
So good afternoon, Chairman and everybody. So my topic is about protect side branch in bifurcation PCI. So bifurcation PCI is very popular in PCI. Is about 20% of PCI. They are bifurcation lesion, and the side branch occlusion happen about up to 16% of bifurcation PCI. So according to the COVID-2 study, 1/3 of cases unable to restore blood flow, and it's increased the myocardial infarction or death more than 2 times. So the mechanism of side branch occlusion, there is 5 mechanisms. First of all is coronary SIF, and the second is black sheep, and the third one is osteodissection, the thrombus formation, and the last one is the spasm. So the risk of side branch occlusion in the region score, there is some 7 risk of certain risk factor of side branch occlusion. First is black distribution. If the black distribution at the same side of side branch is increase the risk of side branch occlusion. And the main ratio is timid flow. The third one is the procedure diameter stenosis of bifurcation. And the bifurcation angle is the bifurcation angle more than 70 degrees. It increase the side branch occlusion. And the diameter ratio between the main branch and side branch. And the last one is the diameter of stenosis of side branch before main vessel stenting. So there are so many techniques of protect the side branch. They can classify about 14 of techniques. So many techniques I never tried before. I hope in that after presentation, when they discuss, I can learn from you about your experience. So we can classify 2 main groups of technique. That is the zero-wise technique and zero balloon technique. So the zero-wise technique is the most widely used in the technique that we use. But zero-wise technique did not reduce the rate of side branch compromise, except it's providing a path to recross. And we can use a low profile balloon to expand underneath the chart to the cerebral ostrum to rescue the cerebral occlusion. So after that, we can do POT to correct the stent deformation. So gel balloon technique. Gel balloon technique, we put the balloon in the cerebral and deploy the stent. After deploy the stent, we can inflate a balloon in the cerebral and then do the kissing. The other technique after balloon in the cerebral and they do post-dilatation. One randomized trial compare gel wire technique and gel balloon technique. They show that gel balloon technique is superior than gel wire technique, reduce the cerebral occlusion. In gel balloon technique, the cerebral occlusion only 9%, and gel wire technique is almost 20% is occlusion. However, there is no significant difference in 1 year of MACE. So, gel wire technique, we can, after gel wire technique, we can use the balloon to dilate in the cerebral and the POT. That's so, gel balloon technique was described in 2010 by Dr. Bersuta. Sorry, I go back. And this is the gel semi-inflation balloon technique that we use the balloon in the cerebral and dilate to in the membrane stent with in the cerebral, we go up with a low vessel about 3 to 4 atm. In the membrane, we deploy the stent at a normal vessel. When we deploy the stent, can switch the contrast to the balloon in the cerebral, and then we do a POT. The other technique, they use the kissing, stent and balloon in the cerebral, and then do post-dilatation. So the other technique is gel corset technique. We use the corset in the cerebral, and then deploy the stent in the membrane and rewind to the cerebral, then post-dilatation. Gel etch technique, they put the wire in between stent and balloon before deploy. Then after that, they do kissing balloon. So gel balloon technique and then do POT. We balloon in the cerebral and deploy the stent, and after that kissing, and then do POT. And rescue balloon gel technique, they use the balloon in the cerebral, and after deploy the stent, you can inflate the balloon and then do a POT. And rescue inverse cross technique, they put the balloon in the cerebral and deploy the stent. After deploy the stent, they inflate the balloon in cerebral, and then put the stent in the cerebral. After that, we cross the wire to the cerebral, then do kissing. So one of the techniques that's introduced in 2022, they do the proximal optimization and with the kissing balloon inflation technique. So after deploy the stent in the membrane, then do the POT, we put the balloon at the side brain. But in the ostium of the side brain, do kissing, then finish. So in conclusion, zevolutinists have been the most effective technique to prevent side brain compromise in provision stenting. So zevolutinists were further modified many techniques according to the balloon position, inflation pressure, and inflation timing. So understanding the mechanism, independent predictor and risk to protect the side brain. And up to now, absent of robust clinical data to determine which of techniques are the best. So alternative technique to choose when dealing with the treatment of bifurcation lesion. Thank you very much for your attention.
Yeah, thank you very much for a very interesting talk of Dr. Nguyen Trung Quoc from Heart Institute Ho Chi Minh City. Most known technique to protect the side brain in bifurcation PCI. What do you think when the most important risk of the side brain occlusion? What do you think is the side brain, ostial side brain stenosis, or the diameter between left main brain and side brain? This first question. And why don't you use the technique that you kissing balloon before you put the stent in main brain and you rewire the wire in the side brain? This is my favorite technique. Yeah, because when the stenosis of the ostium of the side brain is 90%, normally we will lose the side brain. And if we do the technique kissing balloon first before we put the stent in the side brain, we avoid to share the balloon in the side brain.
Yes. So thank you for your question. According to in my opinion, I think that the stenosis of ostium side brain is important to the risk factor of side brain occlusion. We can do a kissing balloon before deploy the stent, but when we balloon the side brain, it may make a dissection. When it have a dissection, we cross. We require the stent. Maybe it's go to intima, but it's very popular to do kissing first. Yes, thank you.
Yes, can I have some technical issue regarding the gel balloon? So first is that if you decide to use a gel balloon technique, then any recommends of the guiding, it should be 6 or 7. So and the second thing is how do you choose the balloon for the side branch? Can it be a 2.0, 2.5? Is it a short balloon or long balloon? Because some operator, they say that they will choose a long balloon. So that's a gel balloon in the side branch will be longer than the stent. Yes, so what do you think?
So very good question. Thank you. For the gel balloon technique, they have 2 risks. One risk is the malformation of the stent, and the other risk is the balloon were entrapment, were trapping. So the balloons, we should give a very good balloon. Small balloon, the size of balloon is less than the size of side brain, and half of membrane. And the length of balloon is long enough to the proximal of a balloon have at the same level of the proximal stent edge. Yes. And
I have some comment on this because we try to use this technique is try to preserve your ostium of the side branch. So I think any balloon dilatation before you wiring, I think it should be avoid, because if you just do like a balloon dilatation or kissing balloon, that may happen that sometimes osteo dissections. Yeah. So if you want to use this concept, the gel balloon, the balloon should be lesser than the actual vessel size. So if you use one to one and you just use some balloon dilatation, then it may be dissection.
yes.
Thank you.
Thank you.
For the balloon, when we do kissing balloon, will provoke the dissection of the side branch. And you know that finally you should do the kissing balloon if you gel balloon. And if you gel balloon, you do the dissection after you put the stent in the main branch. Is worse than you do kissing at first. You do kissing at first? You can from the beginning provisional stenting. You can change your strategy to the two-stent technique. And if you have the dissection of the side branch, you put the stent in side branch first and then stent in the main branch. Easier than you put the stent in main branch and you cross the stent through the mind of the stent is very difficult. And I think that the strategy that you do the kissing balloon first always better than you final kiss and you do the dissection of the side branch. And we move to the final talk, final presentation of Professor Dr. Hoang Van from the Heart Hospital of Hanoi. How to use the imaging to optimize the result of the left main PCI. We invite Dr. Hoang Van.
Good afternoon, ladies and gentlemen. Now it's late, so I hope today bring you a lot of joy and success. My topic today is how to use imaging to optimize the results of left interventions. So, as you know, left main coronary artery is supply about 75 to 100% of heart blood. So, significant stenosis may be it's a high risk of catastrophic outcome. So, patients with significant left main disease, they must to be checked by CABG or PCI to reduce the risk of death. Now, some data show that we use IVERS or OCT to guide left main intervention, maybe will improve outcome. So ESC 2024 guideline for using imaging in PCI of left main is a class 1A. So IVERS and OCT now has many benefits for guide left main interventions, like accurate side vessels, blood balloon quantifications, bifurcation assessment, and lesion severities, assessment of calcified blood and PCI stent placement and expansion, identification of X decantation and manipulation after stenting. So, it's one of the benefits of the imaging is a pre-procedural assessment. You can see it's a cross-section views in IVERS. You can see assessment lesion, morphologies, and severities. You can see, and IVERS can show us the blacks is a considered calcified, calcium, or fibers, or lipid bone, or something else. In the non-longitudinal views, as Iver can can show us the details of the bifurcation anatomy and the blood print around the bifurcations. And ends and imaging is also useful to determine the nerve main stenosis. So if we use IVERS, its minimal movement errors in nerve main is less than 4.5 mm squared. It's a significant stenosis, so institutions need to be synchronization and revascularization. And if the minimal movement errors is more than 6 mm squared, in this students, it's only medical adjustment. But in gray zones, its minimum movement is a range 4.5 to 6 mm squared. In this patient, we have to use FR or IFR to check significant stenosis or not. If it's a FR or IFR, so significant stenosis, it's just this situation patient have to revascularization. If not significant stenosis, we only do medical assessment. So OCT PCI is the same ways compared to IVERS, but OCT is much better solution. One more benefit when we use imaging to ensure procedural guidance. You know, as in procedural guidance, we have in the imaging can help us to determine 3 points. It's a point number. Point one the imaging can show us where the landing zone is good. The good landing zone is defined as confidence is less than 50%. And second point is the imaging can determine the diameters of stent sites. If we use Newman diameters, then the largest diameter of Newman is stent size. If we use the vessel diameters, then the 90% of vessel diameter is stent size. As one more option, if we can use the vessel diameter minus 0.25 diameters as diameters. And when we assess lesions, we had planned detailed plan for DCP for napkin PCIs. And in this situation, and in this clinical practice, some patients, sometimes we don't know where is the good. The position of stent inside branch. In this case, you can see in around the bifurcation, you can see the 3 lines. In red lines, you can see red lines come over the carrier. But here is not good position for stent inside branch because it's not complete coverage. It's a complete otium. But line number 4, you can see here is the good position of stent because it's a complete, in full complete coverage, full complete coverage of circumflex otium. You can see here when stent position here, we see the IVERS. On the IVERS, you can see the shape, the overall shape, like this. And here position is a good position for stent inside branch, in the complete branch, because it's a complete complete otium. Send in IVERS, you can see the overall shape. Yeah. Then apply the clinical practice. Here is a deep IVUS. IVUS here is a very suitable stand size, and so we equalize position of stand is the same, and the same here is the upstand. It's okay. It's a very good result. So the last benefits when we use the imaging to judge after stenting, we had imaging could have to 3 points to check 3 points. So point number 1 is stent is full expansion or not. Is good expansion or not? Is good expansion defined as the minimum stent errors is more than 90% of Newman reference. If not good expansion, we have to both dilate one more time with higher pressure with NC balloon higher pressure. And the point number 2, we can see the stand good apposition or not. Good apposition is defined as no gap between stand and vessel rod. If not good apposition, we have to post dilate again with semi-camlin balloon. And the last point is we check the stand in the X digestion or not. If the digestion is little or middle digestion very heavy. Heavy here defines its digestion more than 60 degrees. In this situation, we have one stand to shield this digestion. So OCT to both besides is the same way. The digestion must better the solution. Okay. So it's a summarize. It's time to summarize and touch on some points. So imaging is useful for our precision in lab-made intervention. IVUS and OCT guide lesion assessment, PCI plan, and post-research optimizations. And imaging tries intervention, improve outcomes, and reduce complications. So that's easy guideline now. Is as you comment, use imaging to guide napping PCI. Is class number 1. I thank you for your attention.
I have one question for Dr. Văn and Dr. Huy. All the patients you do the left main PCI, you use the IVUS or OCT, or some patients you use only the angiogram?
Yeah, so in my class, in my centers, we have the IVUS available. So when we do napkin PCI, we always check by IVUS before and after. Yeah.
Okay. And Dr. Huy?
Yes, I think the IVUS OCT now must be a part of left main interventions. So OCT is not available in most of hospitals in Vietnam, and we are still in the learning curve of how to use OCT for left main. IVUS becomes more familiar. So I think now IVUS is a must. Yeah, I think if you want to have a good result of left main PCI, then you should not just base on angiography.
And Professor Lam Ho, you prefer to do the IVUS or prefer to do your OCT for left main BCI?
For left main, definitely I will choose IVUS. Honestly.
Now on this session, thank you. Thank you for a very interesting talk from Dr. Hoang Văn. And for this session, first we already hear the talk of the Dr. Rajagopal, DCB angioplasty in the normal CAD. We hope that in the future we always use DCB because the best stent for the patient is a no stent. And then we can hear the talk from Associate Professor Huan, rotational atherectomy, and how when we use the rotaplator in the calcified lesion, and the benefit of the rotaplator when we use for calcified lesion. Professor Lam Ho gave the very interesting case, the case of the cardiogenic shock after PCI, and I think that it is a very challenging case. Professor Lam Ho already resolved for this patient how to use the mechanical support and drug for this patient. And then we hear Dr. Nguyen Trung Quoc give the talk, the most know the technique to protect side brand. Because side brand is very important when we do BCI. The side brand, big side brand, we should not lose when we do BCI. And we have so many techniques to protect the side brand. And final, we hear Dr. Quang Huan is how to use the imaging to optimize the result of left main BCI because now the guideline, American guideline, Vietnamese guideline, European guideline show that imaging technique, IVUS and OCT are the best when we do the class 1A, when we do the left main BCI. Yeah, thank you, chairperson, co-chairperson, and all panelists, and all of our colleagues here to attend this session. Yeah, thank you. And now we're closing this session.